of TB DOTS, Sindh Province. Presenter, Dr. Naveed Masood, Field Epidemiology Training, Pakistan. Please. You have 10 minutes and 10 minutes only for the discussion.
Bismillahirrahmanirrahim. Good afternoon, ladies and gentlemen. I am Dr. Naveed Masood Mehman, alumni FLTB Pakistan. Today I am going to present evaluation of surveillance system of TB DOTS in Sindh Province, Pakistan. As you all know that tuberculosis is a significant health problem throughout the world, causing widespread morbidity and mortality. The tuberculosis infection is caused by microorganisms known as Mycobacterium tuberculosis. Organism can infect all age groups and any sex who is exposed. Morbidity and mortality due to tuberculosis is high in poor countries and population having low socio-economic status. Globally, there were an estimated 8.7 million new cases of tuberculosis in 2011. So we can say that on every 100,000 population of the world, there were 125 cases of tuberculosis. Globally, 22 countries are reported as high burden countries, which carries around 80% of the total tuberculosis burden, while EMPHNET has 0.65 million cases, which accounts 7.7% of the tuberculosis globally. In Pakistan, Pakistan ranks 5th amongst tuberculosis high burden countries and responsible of 5.1% of total national burden. In EMPHNET region, Pakistan ranks 1st and contributes 61% of the tuberculosis burden. Every year, about 0.42 million new tuberculosis cases are being reported, and half of them are sputum smear positive. In Pakistan, WHO estimates that 430,000 all types of tuberculosis cases were accounted with an incidence of 231 per 100,000 population, and the prevalence of the tuberculosis stands at 364 per 100,000 population. Tuberculosis is responsible for loss of more years of healthy life than any other communicable disease, which mainly targets the poor population and is one of the priorities included in the Millennium Development Goals. And due to high morbidity and mortality, it is significant to evaluate the system. Goals and objectives of TB DOTS strategy, and the goal is to reduce the global burden of the tuberculosis by 2015 in line with the Millennium Development Goals, while the objectives are to achieve universal access to high quality care for all people with tuberculosis, reduce the human suffering and socio-economic burden associated with tuberculosis, protect vulnerable populations from TB, TB-HIV and drug-resistant tuberculosis, support development of new tools and enable their timely and effective use, protect and promote human rights in TB prevention, care and control. The system was evaluated to identify its strengths and weaknesses and then recommend certain amendments to improve the system to achieve the required results. A study design was descriptive evaluative study which was conducted at Provincial Directorate General of Health and various sentinel sites at district and town hospitals from the November 2012 to January 2013. All stakeholders of the TB DOTS program were identified and engaged them in the evaluation process. For data collection, the semi-structured questionnaire based on updated CDC guidelines for evaluation of public health surveillance system 2001 were used. Face-to-face interviews were conducted to get key information and desk review for data and reports were done. Qualitative and quantitative assessment of system attributes were done, while system evaluation attributes were ranked as good, average, and poor. This is the flowchart of the TB DOTS surveillance system, in which after every quarter, within 2 to 4 days, the data from diagnostic and treatment center reached at district level where data discussed in quarterly review meeting. And from the district within 7 days, it disseminated at provincial TB office at Directorate General Health Services. And within the 14 days of every quarter, it further disseminated to the federal level at the TB National Control Office, Islamabad. As far as the simplicity is concerned, the case definition is simple and easy to understand. System was uniform while staff is trained in data management and using standard and same data formats at every level. While with regard to the flexibility, system can accommodate new health-related events and can integrate with other surveillance system. Completeness and validity of the recorded information reflected good quality of the data. Data format were complete and accurate using web-based collection and management software for data analysis. As far as system only exists at districts, towns, and some rural health centers, less public-private partnership owing to less involvement of the private hospitals, clinics, and laboratories. And there is a less coordination with other health system. The sensitivity of the system was 44.6% with the predictive value positive was 45.3%. As this system is working in all districts of Sindh province, Pakistan, while the system does not present at basic health unit level, private sectors are less involved. Systems share the data from sentinel site to district and then provincial and federal level on quarterly basis. Owing to this, system may be delayed or to pick the epidemic. System is reliable and has ability to collect, manage, provide data when needed. Well equipped with in-computer and other logistics. It is concluded from the study that TB DOTS does not exist at primary level, while there is a poor response from private sectors with less public-private partnership. As the LHWs are involved in the system and with no integration of other health system, and there is a quarterly reporting mechanism, so the epidemic of the disease may be delayed or missed. It is highly recommended that this system should be established at primary level. Private practitioners should be sensitized so sensitivity could be improved, and to enhance public-private collaboration and integration with other systems should be increased. LHWs are working at grassroots level, so it is significant to involve and train them for reporting of the tuberculosis suspects. In order to pick epidemics early, it is pertinent to improve the monthly reporting mechanisms. Thanks for your attention.
Thank you very much, Doctor, for the nice presentation. Now we open the floor for some questions. Any questions, comments, or clarifications?
Okay, thank you very much. Good job for our presentation. So in looking at the attributes of the system, you said that the flexibility of the system is good, and it can actually integrate with other surveillance systems. So what type of system is this? I mean, in terms of I would say the systematics, the system specifications. Is it like a DOS-based system, or is it like a Microsoft system? What type of system is it? And when you say you can integrate this with other surveillance systems, which other surveillance systems is it actually integrated with, or you have seen it actually integrate with?
Yes, actually the TV DOS system is happily working over there, and it would be high that if there's a integration of the AIDS acquired immunity deficiency program and leprosy program, and if we would have an integration of these programs, it will be wise and we can detect more TB suspect in the system. So system as far as the flexibility is concerned, if there is we accommodate and we integrate the AIDS program in system, that is, we can with additional resource and time and allocation, it can integrate. We can integrate this system with the AIDS control program.
But has that been done, or you think it can be integrated?
As it's not been done, but I just recommend that it should be done.
Dear colleagues, you are kindly requested to introduce yourselves when asking, and be brief, asking to the point and exact things. Thank you.
Thank you for, my name is Mohanad from EMPHNET, so thank you very much for nice presentation. My question about the recommendations. So when we recommend, to more, to enhance public health-private collaboration,
Yes.
Did the government take any action toward this recommendation? So how we can see the effect of your study or evaluation of those TB surveillance on the public health effect? I will not say impact, but at least the effect of such study. Is it easy to suggest for the public health officers or the policymakers to collaborate more in the private sector? So how we can convert, or how we can make our recommendation more valid to the policymakers? Thank you.
Yes, this is very important because this, as the in rural Sindh, especially I mentioned here regarding the Sindh province, because the most of populations who are residing in the rural setup, and most of the TB suspects who firstly come to the private sectors and then up to the government sectors. So here this sensitivity is low because there's most of the TB suspects who usually seek the treatment to the private sector. So while the commitment and while the involvement of the government and we should improve here the public-private partnerships to bring in the nets, surveillance net of the private sectors. So we could improve the sensitivity here.
I have a question for you, if you don't mind. You mentioned the lady health worker. Can you elaborate on this lady health worker?
Yes, this is because lady health workers, this is the backbone of the national program, as they are working in the rural health centers. The already program is, because it's not resides at the primary health level, so if we involve the lady health workers, we can improve the sensitivity. Because these are very important component of the lady health workers are very important in the national program. So this is very important to involve the lady health workers in this system.
You mentioned something about the representativeness. You say that's average, because you don't include all the basic health units in the world.
This
is
is
it
some
necessary to
rural
include
centers.
all of them?
Yes, almost most of the BHUs, the program does not exist at the basic health unit level. It is present at the district hospitals, talc hospitals, and rural health centers, but not at the first primary care level. So from the rural side, people, they come to seek their treatment at the talco level and rural health centers. So despite the people and quicks already working over the rural side, so usually most of the peoples go through the at private sectors and quicks. So it is very important as far as the eligibility is concerned, it should be involved in deeply to bring the program more successful.
Okay, thank you. Any more questions? Thank you so much, Victor. Thank you. Okay, then the next speaker will be Dr. Ayad Karim from Iraq PTP, please.
physical, psychological, social, and environmental domains. Second, to describe demographic, socioeconomic, and medical factors associated with the quality of life outcomes in TB patients. Methodology. Study design and study population, a cross-sectional study of all TB patients from Al-Karkh part of Baghdad diagnosed during data collection period. Settings, chest and respiratory consultant clinic and districts TB coordinating units in Karkh side of Baghdad. Inclusion criteria, all TB patients who are on anti-TB treatment, age 15 to 65 years, exclusion criteria, TB patients having any comorbid disease, TB patients who refuse to participate. Tool of data collection, a structured questionnaire used to gather data on demographic variables filled through direct interview with patients. Data concerned with quality of life obtained using the standard questionnaire WHO quality of life brief. This is the way how to calculate the equation of computing domain scores. This is raw score and how to transform to a transformed score. This is the way how to transform the raw to the score, the numbers of raw scores, and to transform the scores from 0 to 100. Data analysis, statistical package of social sciences version 18 used for data input and analysis. Scoring and data analysis of quality of life done according to the WHO brief scoring and analysis. Type of quality of life scoring used 0 to 100. Variation of scoring of quality of life within each domain according to demographic and medical variables were analyzed using t-test and ANOVA. Results, 103 patients interviewed, 100 accepted to participate, response rate was 97%. This is the description of study sample, gender, male and female. Female, the most participation is 58%. Age group above from 15 to 45, the large number, about 60%. Occupation, housewife, 38, then the freelance, 26. Type of residence, owned, 53%. Crowding index, less than 5, 90%. Education, secondary, have the most participation is 39. Marital status, married, 57. Smoking, no non-smoker is 60%. Phase of treatment, an intensive phase, 57%. TB category 1, 75%. Site of TB, pulmonary, 66. About the physical domain, psychological domain, social domain, environmental domain, we record about 47 and less than for all these domains, less than 50%, 50 scoring. Variation, table 3, variation of scoring quality of life within each domain according to the demographic variables by t-test. The significant results is for crowding index less than 5 and more than 5, 64 for the psychological, social, and environmental. Type of residence, it is significant for environmental. Variation of scoring quality of life within each domain, variables by ANOVA. Education is significant for physical and environmental, and marital status is significant for social. Employment is significant for physical. Variation of scoring quality of life according to medical variables, it's significant for treatment phase, physical domain and environmental domain, and category of TB is significant for physical domain. This rating part of the quality of life of TB patients, which is generic part, we see that there is very poor, and neither poor or good, very good. Very good is 0%, and neither poor nor good is the highest recording, then poor. And the figure 3 is rating general health of TB patient by gender. Dissatisfied, recording the highest number, highest percent, 45, about 45, then the satisfied and very satisfied, very dissatisfied. Very satisfied is 0 point. Conclusion, quality of life of TB patient is considerably affected by the disease. Quality of life of TB patient differ according to the demographic crowding index, type of residency, health education, employment, marital status, and medical characteristic, treatment phase, TB category. Recommendation, assess patients' quality of life besides clinical, radiological, bacteriological findings. TB control program needs to develop strategies to improve the quality of life of TB patients. Thank you.
Okay, thank you so much, Dr. Ayad. Now the floor open for a question. Yes, please. No, just a minute, Karima.
Thank you for your presentation. But I'm just curious, why did you pick only the Karch?
Karch side?
Yeah.
Because I am from Karch side. I employer in the Karch side.
Thank you.
Yes.
I'm Jamal Wadi Jordan, infectious disease. I may have missed a point. Maybe myself I didn't
Yes.
pick up this point. This is a prospective or retrospective evaluation of patients or what?
Cross-sectional.
Yeah, cross-section at one
Yes.
point. So along all patients with TB? So,
Yes.
Okay. So some of patients, they were on treatment, some of the other are not?
TB on TB treatment.
Okay.
All of them.
I mean, when you do cross-sectional, all patients are on treatment, right?
Yes,
And
because
not-
when I make a questionnaire, because they refer to the
to the clinic for
Clinic
medical.
for-
So while on treatment, you did the study
Yes.
for the quality of life. Thank
Yes.
you.
Any more questions?
I have no question, but I would like to express deep thanks for a very important selection of this topic, because quality of life is concern of health.
Yes,
Thank you for
thank
this presentation.
you. Thank you.
Thank you very much. We save a time, so we will shift to the last speaker. I would like to mention that one of our presenters is absent, so we have only 3 presenters here. We will shift to the last presenter, Anzar Ahmed, Dr. Anzar Ahmed. He will present his topic, risk factors of multi-drug resistance TB in category 2 cases in Lahore, Pakistan.
Punjab, which is a case control study. drug-resistant tuberculosis, especially multi-drug resistant tuberculosis, poses a substantial threat to TB control programs globally. According to national TB guidelines, MDR-TB is defined as TB caused by organisms that are resistant to isoniazid and rifampicin, which are two first-line anti-TB drugs. According to WHO, MDR-TB requires prolonged therapy, including second-line anti-TB drugs, which are less effective, expensive, and more toxic than first-line drugs. Globally, 5% of TB cases were estimated to have MDR-TB in 2013. That is 3.5% of new and 20.5% of category 2 cases. Drug resistance surveillance data showed that an estimated 480,000 people developed MDR-TB in 2013 and 210,000 people died globally. According to WHO, Pakistan is ranked 5th for TB and 4th for MDR-TB disease burden worldwide. Approximately 420,000 new TB cases emerge every year, and half of these are sputum smear positive. National TB Control Program Pakistan conducted a drug resistance survey in 2012 and estimated that percentage of TB cases with MDR-TB were 4.3 and 19.4% among the new and category 2 cases respectively. Objectives of the study were to determine the distribution of multi-drug resistant TB in category 2 cases in Lahore, Pakistan, to evaluate the risk factors of MDR-TB in category 2 cases, and to propose recommendations for improvement. Punjab comprises more than half the population of Pakistan, and Lahore is second largest city of Pakistan, having 100 million of population. It is considered to be one of the 30 largest cities of the world. This case control study was carried out in 3 different tertiary care hospitals, implementing programmatic management of drug-resistant TB in Lahore, Pakistan. We conducted a case control study in 3 tertiary care hospitals, implementing programmatic management of drug-resistant TB in Lahore from July to December 2014. The target population was MDR-TB patients who were registered at PMDT sites. Pre-tested structured questionnaire was used for data collection, and data was collected from medical record in the form of electronic nominal review system from PMDT sites. Data was analyzed using SPSS 17, frequencies were calculated, and risk factors analyzed using odds ratio with 95% confidence interval and p-values. Cases were defined as the MDR-TB cases residents of Lahore district confirmed by drug susceptibility test and culture test during January 2010 to December 2014 from the PMDT sites of Lahore, which showed relapse, previous treatment failure, loss to follow-up. Controls were selected with the same criteria as for cases, except that the strains were sensitive to both isoniazid and rifampicin by drug susceptibility test. Area and age were matching parameters of controls, and cases and controls were taken in a ratio of 1:2. All 316 patients were enrolled for the study having drug-resistant tuberculosis. After applying the inclusion-exclusion criteria, 146 were excluded from the study. 13 of them were negative after drug susceptibility test, and 21 had less than 30 days history of second-line drug use history. 42 were having missing information, and 70 refused to participate in the study. Further, they split into category 1 with 110 patients and category 2 with 60 patients. 12 patients were excluded because they were sensitive to isoniazid or rifampicin, and 9 were excluded because they had resistance to isoniazid or rifampicin. 8 patients were excluded from the sensitivity group because of not matching with cases, and 6 patients were excluded because of not matching with controls. Among 45 category 2 cases, the mean age was 32 years. Amongst them, 23 out of 45 were males, and 42 out of 45 resided urban area of Lahore. Smoking and previous history of tuberculosis were more prevalent. And in the lower socioeconomic status were 24 out of 45. MDR-TB was found to be more prevalent in the most productive age group 15 to 45 years. 39 were pulmonary and 6 extrapulmonary type of MDR-TB. 43 out of 45 were having previous history of tuberculosis. This graph shows the cases reported at PMDT sites 2010 to 2014. On x-axis years and on y-axis number of cases. It shows an upward trend. MDR-TB cases are steadily increasing. This table is showing town-wise distribution of cases of MDR-TB and attack rates. We see that the Ganjbakhsh has the highest attack rates, followed by Shalimar and Kent. These are some risk factors analyses. MDR-TB is more prevalent in the smoking group, 40 out of 45, followed by pulmonary type of MDR, 39 out of 45, and previous history of tuberculosis, 43 out of 45. From the results, it is concluded that smoking is a main risk factor and most affected age group is 15 to 49 of age group which are young and productive individuals. MDR-TB is more prevalent in pulmonary type of TB cases. According to results, risk factors of MDR-TB among enrolled category 2 cases are alarmingly high. So it is recommended that smoking cessation programs need to be integrated with TB control activities. Focused interventions for prevention of TB must be designed targeting the young age groups, like health education and awareness sessions were suggested to sensitize the community. Strict monitoring and follow-up of the pulmonary TB cases for early detection of MDR tuberculosis. Thank you very much. Any questions, please?
Thank you very much for the nice presentation and keeping with the time allowed. So we will turn to the floor for questions, comments.
Thank you very much. Nice presentation. So in the recommendations, you're saying that, can you go back to your recommendations? I think the second bullet was focused interventions for prevention of TB. So what focused interventions are you specifically referring to for prevention of TB?
These may be different, but I think the main thing is that 15 to 49 age group, that should be focused, and health education and community participation. These are the important things that should be focused.
Okay. Because, I mean, the reason why I'm actually asking you, I don't think it's done in Pakistan, but you know, when you're looking at prevention of TB, you basically think about prevention of latent TB infection. So you actually have to screen a lot of, I mean, you have to screen the people who might be at risk, who might be contacts. I mean, at least for WHO does recommend, like, for the context of a TB case, you can actually, you know, give them treatment for latent TB infection, where you can actually test them in the context of Pakistan. If you can probably do a tuberculin skin test, but that might actually get affected by BCG vaccination. But otherwise, you can also use some of the interferon gamma release assays, you know, like quantiferon or something like that. And then if you do actually have them positive among the contacts of a TB case, then depending upon the susceptibility of the case, the contacts can be treated for latent TB infection treatment, you know, with isoniazid for 9 months or 6 to 9 months, or for rifampin for about 4 months. So when you talk about the focused interventions for prevention of TB, especially among the contacts, I mean, that is something that might be something to consider. I mean, the other aspects are important, but if you really want to prevent TB, you have to think about those. Thank you.
Thank you.
Assalamu alaikum. Hatim Jabir from Palestine Community Medicine Specialist. First, I want to thank you for the good case control study and the results. My two comment or questions first. For last 5 years, there is increasing in numbers of patients with multi-drug resistant or increasing percentage of patients. It's
Sorry,
different approach.
I did not understand your second part of question.
Yeah. The second question is, among those patients with multi-drug resistance, is there any healthcare workers?
Sorry, I could not get your question.
Among patients with multi-drug resistant TB, is there any healthcare worker patient?
Yes.
The patient of the patient. Is
These
there
category
healthcare
2
workers or not?
patients are actually the patients who already might have they were in the first category, they are already been use these medicines, but they are used to be in Pakistan health supporters. They used to be as nominated as health supporters. They give them medicine in the morning and they write it up in their records. I think I answered your question or not. Yes. Pakistan, not in category 2 patient, they are only in category 1 cases. No, no. There are no health workers in category 2 cases.
Any more questions? I have a question for you, Doctor. You mentioned in the title of the presentation a retrospective case control study.
Yes.
Why this piece of a retrospective? Why this case control study?
Because I had started from now to from 2010 to 2014 years. I choose that time of period because I have to go back to 2010 and to enroll the cases.
Yeah, this is my point here, that all the information you obtained, you are getting them from the records.
Yes.
And I will assume that not all the information are of high quality available in the records.
No, we got the information from the records. They are like demographic addresses, and we did questionnaires, and we used to do that pre-tested structured questionnaire.
Yeah, this is the point that I think you end with
that's
a small
how we collected the data.
Yeah, you end with limited number of variables, and early you mentioned that smoking is the most important
Yes,
risk factor. So I think if we think in the other way around, if we are going, and this is probably a project for FETPs in the region, we can do that jointly. If we think of conducting the same study using the new cases who appear to be MDR now, and we are going to have a comparison group in order to have large number of variables in order to identify exactly what are the potential determinant of MDR, not only smoking. I think that we will have the capacity to obtain good number of variables through direct interview, having high quality information from them. So this is just a comment and a suggestion.
Okay.
Probably we can work on that.
Thank you.
Okay, thank you.
Regarding the case control study and risk factors, I think many things should be studied and to evaluate. Did you make a literature review so you're concerned about many factors that can be affected and study their importance in the multi-drug resistant TB?
Yes, we did the literature review as well. We did that.
What other factors can affect this
Uh,
other than smoking?
The other factors could be lower socioeconomic status, the poor people, and mostly the category 2 patients are actually who did not got their full treatment of tuberculosis actually. They were enrolled in category 1 and they somehow lost to follow-up or relapsed. They did not fully treat it. I think these may be the other variables as well.
Thank you. Other questions? Thank you very much for the
Thank
nice
you.
presentation. So we can announce the end of this session because we have only 3 speakers. Thank you very much for your attention and contribution in this very valuable session.